Hello, everyone, and welcome to the Academy for Eating Disorders webinar entitled How to Use Neuroscience to Facilitate Core FBT Interventions with Dr. Tom Hildebrandt. My name is Stephanie Jacobs, and I am your moderator today. If you have any questions or concerns about this webinar, please feel free to reach out directly to Dawn Gannon, Deputy Executive Director at AED Headquarters via email at dgannon@aedweb.org. You can also reach her by dialing 703-234-4125 in the U.S. and by adding a +1 outside the U.S. Just a couple of housekeeping items before we get started. All participants are muted with the exception of Tom and myself. The webinar is scheduled for 60 minutes and is being recorded. It will be posted on the AED website shortly thereafter for AED members to download at their convenience, 24 hours a day, 7 days a week. In just a few minutes, Tom will begin his presentation, after which he will answer questions from the audience. Please feel free to submit your questions to me during the presentation using the chat text box on the right-hand side at the bottom of your screen, and I will read them to him when the question portion of the webinar begins. Tom, let's check your volume quickly. Please just say a few words, and if a couple of participants can let me know if they can hear you by sending a message in the chat box I just mentioned, we'll get started.
Hello, everyone. Hopefully you can hear me.
Thank you, everyone, for letting us know that the volume level is good. Let's begin by introducing our speaker. For those who don't know him, Dr. Tom Hildebrandt completed his undergraduate degree at Vanderbilt University and received his doctorate in clinical psychology from Rutgers University. He went on to complete a postdoctoral fellowship in eating disorders at the Icahn School of Medicine before taking over as director of the Eating and Weight Disorders program in 2008, where he has been continuously funded by the National Institutes of Health. His research interests span three major areas. One, development and evaluation of clinical interventions for adolescents and adults with eating and weight disorders or adults with alcohol use disorders. Two, psychiatric and physical consequences of appearance and performance-enhancing drugs, APED use, or anabolic androgenic steroid use. Three, the biological basis, especially the neuroendocrine and hormonal contributions to eating and substance use disorders. He also enjoys development and application of complex statistical methods to help answer questions in these domains. He is currently chief of the Center of Excellence in Eating and Weight Disorders. He has published over 80 peer-reviewed articles, 14 book chapters, and more than 100 scientific presentations. And he is an active clinician, teacher, and scientist. With that, I will turn the audience over to you, Tom. Thank you.
Thanks, Steph, for the introduction. Welcome, everyone. Thank you for joining us on a Monday afternoon for at least those in the States, even on a holiday Monday afternoon. So I appreciate it. We're going to try this for the second time, and hopefully this time we make it all the way through. We're going to talk about neuroscience and how it potentially can be used to facilitate some of the core interventions in family-based therapy for anorexia. So just as a point of starting, I'd like to give some sense of the kind of things that we're going to talk about, hopefully for about the next 45 minutes or so, leaving enough time to try to answer questions and kind of match the presentation to what your interests are. And see if I can't, get in more depth based on what you're interested in. But the outline for today is really, first we're going to talk about defining the illness for families and how we can use neuroscience to help achieve that goal. Our second major goal, really pulled from FBT interventions broadly, is reframing guilt and blame. I think this has applications outside FBT as well, but we're going to talk about it. And how neuroscience can be used that. And then how, at least in some cases, you can think about neuroscience to help design and kind of implement interventions that target some aspects of the disease. So we'll talk about that, and I'll give an example from the work we're doing here at Mount Sinai about that. So with that, I will also give you some disclosures and hopefully set some expectations about the talk as well. I would argue that compared to a lot of other mental health problems, we know actually very little about eating disorders specifically from a neuroscientific perspective. There are a host of reasons for that. We don't enjoy some of the funding opportunities that occur across other disorders, and that's probably limited us. It's also a hard population to study for a number of reasons, and so I think we can't really undersell the fact that we're still learning a lot from a neuroscientific perspective on particularly how it applies clinically. But I think that for the purpose of this talk, that doesn't matter so much. Because I like to think of it, we're using neuroscience really to support and achieve our goal rather than ultimately to really drill down and prove a theory. So given that, I would also say that I'm going to speak more generally about things than I would if I were giving specifically a talk on neuroscience to a neuroscience audience. I think that there would be different kinds of details, but I like to think of it as I'll use language that I would use with family members, because I think how you talk about neuroscience matters, and I use a lot of metaphors clinically when I talk about these things, and hopefully I'll naturally use the same with you guys when I talk about it. One principle that I tend to stick to when I'm talking particularly to families, and hopefully I do here, is that I'll use only really enough neuroscience to support an intervention, rather than sort of dive into the depth of what we know and don't know about a specific topic, because I feel like patients can easily get lost that way, and it ends up being a disconnect. So really, you're going to hear from my perspective kind of the amount of information you need really to support and execute these interventions. Consistent with that, what I am going to talk about is really a simplification of what is a really complex set of neuroscientific ideas, for lack of a better way of saying it. There are a number of system levels of where we can try to answer and ask specific questions relevant to the things we do in FBT. Don't have enough time. It wouldn't be useful for patients to get into all the depth about all of them. So in some other contexts, I'd love to talk details about some of these things with folks if they're interested. But I think really for today's talk, for the time we have today, I'm really going to be focused on how to use what we know to make a point or to help execute an intervention. Hopefully at the end of this, you guys will have a lot more questions. Usually I think only the best neuroscientific talks really generate way more questions than they do answers, and hopefully this will meet that standard. Okay, so as a point of starting, and I usually talk about this with patients and their families often. I talk about eating disorders and in some aspect of psychoeducation, like to generally think about these things as eating and weight disorders as fundamental disturbances in eating. And for those of you that know the DSM, this is consistent with how the DSM defines it. And then we kind of break it down, and this is how, when I'm teaching it to students and we're talking about it in our group here, we really think about it in two different ways, or two different aspects of these broad constructs that affect everyone. Food avoidance and loss of control or overconsumption. That these two general areas affect the entire population in some way, shape, or form. And so they're common experiences that we can have and we can relate to anyone. That being said, we can talk about subgroups of people that have disturbances within these domains and that they fall along diagnostic categories. And what I've done here is just created sort of a Venn diagram that shows some of the overlap between the different diagnostic categories, but also how they overlap with these two constructs of food avoidance and loss of control. And today, we're going to probably talk mostly with most relevance to anorexia nervosa. We could have 3 more talks about the other disorders, and maybe we will at some point. But I think for today, given what FBT is best targeted for and what it's most useful for, we're going to focus on anorexia nervosa. So that leads us to the question of what is food avoidance. Well, food avoidance, I like to think of it really as a pattern of response to food eating cues that favors reduction in consumption of calories or types of food. It's typically associated with a negative emotional state, and Again, these are the kind of ways that I would talk about it with a family. I would talk about really kind of relating food avoidance to that negative emotional state that's usually keys up for them in terms of the experience of either their child or the family themselves. But food eating cues, these are really diverse things. So this is sort of jargon that we borrow from the way we like to talk about things, but those aren't necessarily the things that our patients will be keyed into. So instead, I'll use examples, things like specific types of food that we know that they're avoiding, internal states, which can also be cues that patients experience or that the families recognize in their children, or environments, places where these sort of cues are really salient and they see this food avoidance behavior occur more often, or sometimes in just response to people. We often affectionately get called the eating police here when we're trying to do interventions, and so we can't think of ourselves as anything else but cues that might trigger some of that negative emotional state, particularly in the context of FBT. On the other end of the spectrum, when we talk about loss of control or overconsumption, our core phenomenon that we think about is binge eating, and of course there's subjective and objective binge eating. Now, most of you know this distinction. It's probably more important for us on the scientific side than it is clinically. Most patients don't distinguish well between these two types of eating episodes, but for our purposes, there is a distinction. When I think of loss of control, though, I think of it as really a disinhibition or inability to stop an unwanted action in response to a food eating cue. And we can think of it as either being really highly reactive to cues, so any of those same cues I mentioned, it could be a palatable food, or it could be a situation or context or an internal state. And it suggests either that there's a sensitivity to reward that makes that cue really motivating, or that there's some deficit, some difficulty inhibiting kind of a reflexive action. One of the core things that we think about is this subjective feeling that loss of control has some component to it that distinguishes it from other types of eating that patients can reliably identify. And as the DSM has loss of control definitions of it, as those of us who work clinically with these populations, they have some description of their own experience that has this sort of feeling state that goes along with it. And these are just a few suggestions: anxiety or anticipation, guilt or regret, craving or desire. Other components that you need to have when you think about defining the illness with families and patients, I think a little bit of starvation and a little bit of adolescence, given that FBT is typically focused in low-weight eating disorders and in adolescent presentation of it. You have to know a little bit about these two topics. And starvation, I think, in particular, is critical to any of the neuroscientific models that we have for eating disorders. And I think it's really a large part of how we can separate self from illness, and that all of us know that we behave, act, and think differently in a context of starvation, and that we can use this to help reduce some of the blame that both an individual and the families experience about the presentation of the disorder. The other thing I think that gets maybe appreciated in the context of FBT is this sort of knowing a little bit about what kind of things are happening pre-puberty and during puberty, because there's sort of really unique developmental windows, and that we have kind of rapid changes that are going on in the brain that we would expect, that are expected, and that these have sort of a natural influence over some of the behavior and some of the affective and other states that patients might present with. The other part of it is to think that some part of that window is absolutely necessary for them to transition into a healthy adulthood. And if we don't sort of explain that or give proper attention to it, we can miss part of the leverage for motivation of the family in terms of really trying to speed up perhaps that weight restoration, or for female patients trying to get their period back, for male patients making sure that their HPG access has also come back online. Because we think that those windows are critical to kind of the social emotional development that they have to go through during this time. It's really kind of unclear, arguably impossible to sort of catch up after that window has closed. And so if you make it through adolescence in a completely starved state, it's unclear if you decide at age 25 you're going to regain that weight, whether or not you can sort of regain what would have been lost about that adolescent development. And I think this is a healthy thing to present to patient or to present to families in particular about the uncertainty about it. I mean, I think we don't really know quite the answer to that, but uncertainty may not be well tolerated in this population, as we'll talk about later, and that may help motivate them to action. All right, so as promised, a little bit of neuroscience. So this is a figure kind of adapted and stripped from a book chapter that is in Neurobiology of Mental Illness. I think Dennis Charney is the editor of it. But it's a more or less one heuristic that we can use to understand what's kind of going on for starvation in the context of this developmental window. And it borrows from some of the existing data that we have, unfortunately, mostly in adults, but probably relevant, maybe even more so to adolescents. So we know to some degree that the trait of harm avoidance and that kind of anxiety or difficulty tolerating uncertainty is part of the temperamental presentation of individuals who develop anorexia nervosa. So as we can see up here in the top, hopefully you guys can see my arrow. We know that also, particularly in the starvation state, and particularly also associated with this trait, that there is a low serotonergic tone, 5-HT being serotonin, and that we have a ratio of two different types of receptors, 5-HT1A and 2A. And again, this simplifies. There are a lot more receptors. There are broader implications within the serotonergic system. But just to give an example, again, as a heuristic to help understand how this might process may be affecting individuals, in particular this adolescent window, what we have here is if in this harm avoidant kind of temperament, we know that you have sort of a high 5-HT1A and lower lower 2A ratio, and this is associated with greater detection of error, sensitivity to error, and a stronger inhibition in the context of uncertainty. So if we think of this imbalance, what it really is the neurotransmission is sort of sending, in the context of kind of uncertainty or error, an inhibition response as opposed to an action response. And that we associate this generally with a kind of harm avoidant temperament. What happens as you get into puberty is you start to experience this ovarian surge. And we tend to think of that mostly as estrogen. Now, the first question you guys should all ask is, why is this so biased towards females? I would ask the same question if I were in the audience. But I would say that estrogen, particularly in the brain, exists. It's tissue specific in the sense of the brain is creating its own estrogen. So while these signals are coming in females from ovaries, as men increase testosterone, they're actually converting more of that testosterone into estrogen in the brain. And then we know estrogen plays a significant role within the brain independent of what's going on periphery. So we can blow away all those stereotypes. Estrogen's important in the male brain as well as it is in the female brain. And so these same things apply, maybe in different ways, but again, details that are not important for our discussion. So, but interesting nonetheless. So as we think of puberty hitting, this ovarian hormone surge, what it does is it would temporarily, anyway, increase the serotonergic tone. So you'd have greater or higher levels of serotonin. And particularly in an environment where you have this imbalance of 5-HT1A and 2A, you would have an increase in dysphoric mood that would be accompanied by greater sensitivity to error, and greater inhibition in response to uncertainty. So typically we think of adolescence as the opposite, but in this temperament, as that kind of general brain arousal and the influence of hormones starts to affect changes in the brain, at least initially we can think of this as increasing pressure on this system, on this temperament. A logical response to that would be, as you start to detect errors more and tolerate uncertainty less, if by chance, whether it be from the environment, whether it be from the family culture, whether it be from an accident of losing weight or otherwise, you decide that looking a certain way is good and not looking a certain way is an error, or not being in control of your shape or weight is a bad idea, you can see that might lead you to be particularly sensitive in this area. And now, as hormones start to flood the brain, you become really sensitive to it. And so then the early stages of AN begin. As you begin to diet, you put pressure on the system that reduces that serotonergic tone. It actually rebalances it, both from a dietary standpoint of the food coming in being less, but also particularly as you cross that threshold into starvation and gonadal hormones, or at least their production, shut off from their external sources, still produced in the brain. But what it would do is it would normalize the sort of brain levels of serotonin at the time. Now, you get this decrease initially in dysphoric mood, but then an adaptation process occurs. Now, that ratio actually increases in the opposite direction. So that balance of 5-HT1A to 2A actually increases in that ratio, and so now you have even more imbalance within the serotonergic system. This is what some of us might refer to, or I might talk to parents or patients about setting the snare. And so essentially, once you've stepped in it, what happens is it tightens as opposed to letting go, which then, as we step into prolonged starvation, what happens is you sort of get an increase in dysphoric mood, and you get a whole range of stress adaptations. And there are a host of other changes that support this, including changes within the stress system, a decrease in beta endorphin, and some of the stress signaling hormones in the brain that make it even harder to recover. So then what happens, right? So as we've caught them in a state of chronic starvation. Logically, what we want to do is refeed them. They should want to get better. They may not, but they should want to. And so we try to help them. We help them by giving them a whole lot of nutrition. And in the process, what do? We turn back on all the pressure to this neural system. And so what we do is we flood it, and we flood it in a way both with the necessary components to make tryptophan, which turns into serotonin. We do it in a way that ultimately, as we did that, would increase the production of it, particularly as the HPG axis comes back online and more serotonin the machinery for producing serotonin gets more efficient. And then all of a sudden we have this paradoxical increase in harm avoidant temperament, which includes this sort of dysphoric mood, error detection, in inhibition in response to uncertainty. So this is one model. Now we could make a whole host of other models that would follow a similar kind of pathway, but we think of it as there's some vulnerability that could occur and exist within an individual, whether it be on the neuroscientific level, whether it be on the temperament level, whether it be on the molecular level. A mixture of puberty and starvation force internally the individual to adapt. They adapt initially in a way that may feel good and positive. In prolonged starvation, those adaptations have other consequences, which make it even more difficult. And then refeeding paradoxically tightens the snare as opposed to letting it go. And so what we end up with is fighting that system, or potentially, as I think some people have referred to on the literature, as a scarring of the system. That prolonged starvation state. We don't know for sure, but we know that in at least weight-restored individuals, that imbalance of 1A and 2A receptors is we've known that for 2 decades or more, is still present well into weight restoration, particularly in adulthood. So it's a good model to think of and to try to explain this metaphor of how the brain is adapting in a way which is paradoxically different than the rest of it. Us. Most of us, I think, going through the same process would experience similar changes, except that we don't necessarily have the snare that would get us stuck. And so that refeeding process, as we get healthier, doesn't tighten. It doesn't make us more dysphoric or more intolerant of uncertainty or threatened in some way. It has the opposite effect. We start to feel better. So that's one model, but I think it's one that I find useful in giving to patients. There are a whole host of things that are true that I tend to leave out in these general descriptions of defining the illness or how it comes to be. One of those is genetic influences or the heritability, in part because I find them very complex, and I think there's a lot more to learn in that area. They can also be dramatically overinterpreted. I think people hear genetics, families hear genetics, they instantly take on blame as opposed to the opposite, which is what in theory we're using to help them sort of make it clear that it's not their fault, it's a genetic illness, but then parents take responsibility for the genetics of it. And I think the nature of heritability is complicated, and so because of that, I tend to avoid it in all conversations related to the illness. I'm sure other people have developed better ways than I have for being able to communicate that information, but I found it to be almost its own rabbit's hole to go down. The other thing that I avoid altogether is comorbidity in the context, and I don't get lost in the sort of this serotonergic model that I presented could easily be applied to just the temperament, understanding the temperament. And so then we get into, well, is it disease? Is it comorbidity associated with the disease? I tend to simplify it and just talk about disease specific and not get lost into some of the other constructs like emotion regulation or reward sensitivity or these sorts of things that we might see in addiction or other kind of models that patients often bring in and sometimes even want to link their illnesses to. I tend to avoid it just so that I don't end up getting lost. Okay, so as a summary, my suggestions would be keep it simple and keep it relevant when defining the illness for the patient. Talk about food avoidance and loss of control, depending on how it's presenting. And edit some of this more diffuse neuroscientific data. Come up with a model, like perhaps the one I suggested or your own, where you can sort of describe onset and difficulty of weight restoration, because I think those are the two key things that you want to be able to communicate to families, because they want it to be easy and that they'll experience any kind of that negative feedback in a way that kind of decreases motivation. We want it to be normalized and have them be resilient to it. The other thing to keep in mind is that starvation is really our foundation for defining the illness, and I think we get a lot of mileage out of that. There are a lot of good resources that you can give people access to help them understand it that I found to be particularly helpful in the context of dealing with questions about the illness. All right, so now we move to our second set of questions about reframing guilt and blame. And really our goal here is to separate the individual from the illness, and how do we do that? Specifically in the context of FBT. So I think, from my standpoint, the first point of intervention is really the intake. And I really start with my first psychoeducation piece, are trying to educate them on some of the common effects of starvation. Again, I don't drill down into details about this, in part because I don't know them well enough at that point to know if I will scare them away or whether or not I'm going to get lost in a debate over one of the details about the starvation. But I will often refer patients to the Minnesota starvation experiment. And I do that. There are a whole bunch of online resources. I'm not going to endorse any of them because I think you should read them and evaluate them for yourself first. But there are a bunch of online resources that talk about that. There have been books that have written on it. You could go to the actual source and read the original experiment or summaries of them. So I think that everyone that deals with this population should read those ahead of time. And read enough of it so that they can really believe that some part of the child's behavior is a common response to starvation. And I think that if you know it well enough to really believe that, then you're in good shape, because that's what you have to communicate to parents. It builds hope and helps them separate this as a sort of definable disease state as opposed to the alternative. Also, the child's affective state changes and persists into that sort of refeeding or rehabilitation, as they called it in the Minnesota starvation experiment. So I think knowing that in a context completely unrelated to anorexia nervosa, starvation had similar effects, and that affective similarities also co-occur, can be really helpful for patients and particularly their families. And so I think that communicating that and having those sort of starvation facts available is essential to achieving that goal. The other thing I try to communicate during that intake is that the central nervous system has become fragile. And I use that as a metaphor a lot because I think it's true. And I will often ask the patient or the family how they would expect their body to respond in the context of food shortage or famine, and how that they would expect adaptation to occur. And there are two things really that come out of that line of questioning. One is that they have to get good at existing on low energy. And so when we think of the adaptations of starvation, you have to get really good at existing on a low energy state, which is true. Paradoxically, of individuals with anorexia nervosa, they seem to be able to persist in low energy states in ways that marvel to the rest of us. The other part of it is that you also, because you're fragile, you become way more sensitive to threat. And I think we cannot underestimate that. You are now a fragile you have now a fragile central nervous system, a fragile body, that protecting it becomes way more important than when you have a high degree of resources. And so I think explaining that and that this sort of natural response where you're both threatened but also existing on a low sort of energy state makes sense for maintenance of the illness when food is threatening. And we're going to talk more detail about that later. Another thing that's often we get stuck trying to explain, and that patients will also drag you down this rabbit hole, is sort of this compensating effect. The idea that they can have normal labs to explain, like there's to explain or rationalize why they don't need intervention or don't need to gain weight. And we can talk about the compensating effect about isn't it remarkable that their body would draw enough from the rest of them to sort of generate normal labs as a way of highlighting just how fragile one's body is in that sense, that it's currently stealing from other areas that it's stored up in order to maintain those normal levels. Sometimes it's just a matter of getting the right labs too. So that's a side talk for another time. But assuming you get the right labs and you still have this sort of normalization effect that patients will often throw in your face, I think that to talk about the compensating effect in starvation is particularly potent. The last take home is just really to drive home. I think that the part of starvation that's underappreciated because we don't experience food as a threat, but our patients do, is that it makes total sense that they would avoid threat in a starved state, that they'd be particularly sensitive to experiencing it. Okay, kind of a stylistic point about how to do an intake that's sort of neuroscientifically informed is that as I'm questioning about symptoms, I'm looking for every opportunity I can to tie symptoms back to that starvation state. And I do that as a point of normalization. And I call it working the symptoms, or that's how I teach it here, is that, as you're going through your diagnostic intake and you're going through your sort of systems review and asking about, disturbances in sleep, you're reviewing labs with them, you're talking about all these different states. You want to continually normalize this to starvation because I think it helps sort of make concrete this difficult to understand illness. The other part about it is the other thing I do within the context of the intake is I look for examples where the patient or the family has run into problems solving emotional or stressful problems. The reason I look for that is that I want to make the point that in the current starvation state, this solving kind of stressful or emotionally difficult problems is expensive, and if they're operating in a low energy state, it's going to be difficult to do because they don't have the sort of energy from glucose on up, right, to some of the things I spoke about serotonin and otherwise. They don't have all systems on go, so it's a really expensive thing to ask them to adapt in a different way. It's not so expensive to ask them to continue to do the same thing. And I think it's important for normalizing that behavior. Them continuing to do the same thing from their central nervous system standpoint is inexpensive. And one of the reasons we find it so frustrating for them to sort of learn or to make changes in the way they think about food or the way they respond around food is because new learning is actually really difficult for them at this state. And I think asking their brain or central nervous system to do an immense amount of new learning is maybe unfair, and why refeeding is so important to the process. The other thing, really taking from some of the great work done by Kate Tanchuria and their group about social emotional learning and recognition in this group of individuals, is we have to recognize that to some degree, at least some portion of our patients really can't, they see threat when it isn't there. They'll take neutral cues and interpret it as threatening, in particular interpersonally, when they see or trying to read the emotional state of an individual, including a loved one close to them. And so they will see things that aren't there, not in the context of actual hallucinations, but they will interpret even neutral faces as threatening. Because they have difficulty reading it. And this may be an inherited trait. It may be worsened by starvation. We're not entirely sure. That's an open theoretical question, and an interesting one. But I think as we're thinking about interventions, we have to think of the likelihood of us being interpreted as part of that threatening system is much higher. And that starvation is going to make sort of reading those cues and getting good at it a difficult process. And I drive home this point in the context of the intake. Okay, so if we're going to conclude this point, what we want to accomplish in an intake is to make sure much of the behavior that we've elicited during the intake we can tie back to starvation, and that this can be resolved, but that it's a difficult road. That it's difficult because the CNS is trying to protect itself from threat, and that this sort of rehabilitation is painful. It's an uncomfortable experience. And I like it to, learning to either manage chronic pain or, to learning how to walk again after a leg injury. It's hurtful. It's easier to not do it. And in our context, it's threatening to be able to continue to do it. The other thing to remember is that emotions are amplified, that threat is more difficult to manage when you're starving, and that the treatment we deliver can easily be construed as threatening. Okay. Lastly, setting expectations about refeeding in this context. You will have to eat and drink more than you think, and that food feels like a threat. And the sort of delivering or setting expectations about eating are in fact dangerous to the patient, given their state. The physical sensations associated with overeating are painful, and that because of this, food does not have the same rewarding properties that it does for someone who has a healthy relationship with food. And so that we can't expect them to just like it. And that's particularly important, I think, for families who get confused about why they just don't eat really palatable food or enjoy it or have that experience with it. I think the other thing that we've come to learn about this population in particular is that they really have a lot of difficulty tolerating uncertainty, particularly about food or the eating environment. And so that uncertainty is really poorly tolerated. And unfortunately, weight regain and refeeding are filled with uncertainty, and particularly FBT, because the patient is giving up control and they're having to sort of trust their parents to do the refeeding. In the process, that we have to understand that it's going to increase or amplify that underlying vulnerability regarding tolerance of uncertainty. Okay, so let's talk about how we might be able to use neuroscience a little bit to guide our actual interventions. So we're going to talk a little bit about kind of disgust as one of the models that we've worked from. There are others, which unfortunately I don't have enough time to get into today. But I'll talk about how we kind of apply it in the context of separating the child from the illness. So we think of it as, the classic Venn diagram that we use in FBT, that there's this sort of weakened central nervous system state where the child and anorexia are similar or the same, and it co-occurs with starvation. As you start to separate the child from the anorexia, you end up eliciting sort of this threatened central nervous system. And this is really the primary intervention. As you start to feed or refeed the individual, you're sort of exposing them to this threat. You're going to get a lot of pushback. It makes a lot of sense. The way I like to think of the last stage of it, really when you get full separation from child and illness, is really that you're really trying to build a resilient child and a resilient central nervous system, one that understands how they got stuck in the snare, and that wants to protect themselves from falling back into that trap because it's so hard to climb out of. And we think of that as the sort of relapse prevention stage. Okay, so what is disgust? So disgust is really, it literally means bad taste. It has a long history in both science and our understanding of just the core experience across mammals in particular. It's very easy to identify in the sense that it has a clear physiology associated with it, including a set of neurocircuitry that we can identify, and an expression that occurs within the face that we can know someone's disgusted, even if they don't necessarily know they're aware of it or can't report it, which I think is important for our patients who may not be able to describe their own emotional state well. It also has implications for understanding some of the other phenomenon about even sort of as we think of it clinically, the obsessive compulsive personality disorder like symptoms. Some of the affective judgments about social decision making or what's right and wrong, that kind of moral disgust has been talked about in the literature. It's not exactly the same as disgust, but when we're trying to relate the idea of disgust to families and their parents, it's close enough for us to be able to make that leap to help them understand. We like to think of disgust as unique, and we talk about a couple core things. It's acquired quickly, very resistant to change, and it's evolved to protect us against feeding behavior that would be dangerous. So things that are poison or that have disease content to it. So it makes a lot of sense. It passes the sort of logic test for describing to families, and so I think it can get them engaged in a way and sort of understanding the disorder in which they can sort of start to reduce the blame and better understand it. We also know just a couple of other things that we can use to help justify our connection to disgust. We know that there's higher levels in OCD, which can co-occur with anorexia nervosa and often in the presentation, and that we know that's higher levels of disgust sensitivity in females, and so there seems to be sort of a gender disparate distribution of this sensitivity, which may help explain why women to some degree get stuck with this more than men do. Okay, so I use this often in the context of describing the anxiety that patients experience. And I may even draw this on a whiteboard for families as a way to help them understand it. But I talk about, we think of anxiety very broadly, and this gets back to that negative emotional state. In most cases, we can identify a negative emotional state associated with food avoidance. We can't really describe the details of it so well. So we try to break it apart into a way that we can. And we think of really three kinds of anxiety that we talk about: fear, worry, and disgust. And we can distinguish them based on kind of this general arousal, not necessarily arousal like central nervous system arousal, like sympathetic and parasympathetic nervous system, but general brain arousal, how active the brain is. And that can correlate, but doesn't necessarily have to co-occur with, say, autonomic arousal. In any case, as arousal goes up, we think of distinguishing, say, worry from fear and disgust based on it's sort of a lower arousal anxious emotion. It tends to occur when you have distance from the threat, so either before or after. Sometimes that worry can be thought of as rumination as well, but after the actual threat. Fear is this really high autonomic arousal emotion that occurs right when the threat is present, and that it tends to go down soon after the threat has passed. Disgust tends to co-occur right at the time of threat, but it persists. The arousal is somewhere intermediate, and it doesn't really go away. That arousal stays around. And so when we think of distinguishing them, we think of worry as this really cognitive process, really categorized by attentional bias to the threat, like over-attending to the threat, tension, preparing the central nervous system for the possibility that something threatening is going to appear in one's environment, but it has this sort of lower level of autonomic arousal. Fear, on the other hand, has a high degree of autonomic arousal. It's really that fight or flight response. It's preparing us to deal with that threat in some way. Disgust is this unique, negative, anxious-like emotion that really increases visceral sensitivity. So one's attention gets focused on the body into the internal states, and it has this decrease of attention. Like you will naturally avert attention and all your cognitive resources away from a cue that's disgusting in preference of attending to the internal cue associated with one's body. And so we think, as we're trying to make the argument that disgust may be relevant for an individual, although all three potentially for any given patient, we will use this to help get them there. This I provide to you guys. I don't provide to patients. It's a little too complicated for them. But as we like to think of it, if you can see up here, this sort of anxiety-producing stimuli, there's either distal or immediate threats. They get engage in appraisal system and ultimately decrease uncertainty, right? So we want to know, is this threat? Should I be prepared? And it'll consult your memory banks. So that memory will affect appraisal system and affect sort of this preparation through interoceptive cues to either fear, worry, or disgust. As we are thinking of an intervention and how it might target this system, what we want to think about is how do we interrupt this pattern? If we think disgust is present, what's unique about it is that this appraisal system is diverted. Remember, I said there's a negative attention. And so all of the attention really gets diverted to this interoceptive experience, which gets coded into memory completely differently, arguably outside of conscious awareness. You have a negative valence towards something you're disgusted by, completely independent of your conscious awareness of it. And so it gets encoded in memory in a different way. And so exposure, particularly that tries to alter the appraisal system of trying to prove to you that this isn't threatening, will not be effective. So logic doesn't work. Now we know this from anyone who's tried to deal with anorexia nervosa. Logic does not work as a way of trying to reduce that anxiety. And quite the opposite. There's an alternative focus on the interoceptive signal as opposed to that logic signal, and this might be why. So what we do, so what does exposure do? As you refeed someone, you're exposing them to this sort of threatening thing. What happens is it's sort of this temporary increase in arousal. You actually support the system. What you hope to do by adding something we'll talk about in a little bit, counter conditioning, is try to change this valence by reducing the associations of threat with this memory. And I'll talk about that in a little bit. But ultimately, what we're going to try to do is transfer positive valence to the memory system as opposed to this aversive disgust experience that gets trapped. Okay. Another thing I don't show to patients, but I wanted to highlight for you guys was just some of the neurocircuitry associated with this disgust model. So as you may know or be aware of, all this sensory information, particularly that related to taste and feeding, is filtered in through the anterior insula or maybe medial insula, depending on what we're talking about or what kind of sensory information. But that's particularly strongly associated with the amygdala. And so this pathway right here is sort of the prime neurocircuitry for experience of disgust. These regions, cortex regions, as well as the sort of more limbic regions like the amygdala, we know have, depending on the neuroimaging study, shown some disparate functioning in folks with anorexia. As we tend to think of how this system works together, as information gets fed in and you have this disgust response, this negative valence is communicated, it's almost experienced like an error. And this could be in the context of a food rule violation. And so the cortex, which is sort of error monitoring the whole system, is really kind of amplifying up the amygdala response as the anterior insula is sending kind of interoceptive information to the amygdala. So it's really saying mistake felt internally. And as that occurs, decrease in reward value, avoidance of food. And we think of it that way. And we kind of talk about this with patients just like that. You have a strong internal gut feeling that tells you you've made a mistake and so that you have to avoid or repair for it. And that's how the sort of neurocircuitry is working to support the system. Over time, we have this whole other set of neural circuitry within the cortex that's really biased towards kind of favoring the feeling of what thinness will do for one self, that it will reduce that interoceptive stress. So as you lose weight, as you protect yourself from the threat, that you can sort of be motivated that it's better than the feeling you would get from food. And so you create this imbalance in value, and that can also contribute to that same motivation for food avoidance. And so we have this whole cortex loop, dorsal loop that we talk about that runs through and kind of motivates that sort of like driven behavior. When we talk about disgust, I tend to leave out that whole cortex loop and really focus on these core pieces. Okay, things that I usually don't talk about with patients because I think they're too complicated really to have a realistic conversation. One is I don't really get into the details of how serotonin or dopamine work or are disturbed in the context of anorexia. I talk about it more of lack of reward or sensitivity to threat. There are also a host of lipid and steroid signals that I think are extremely relevant to the neuroscience or our models of this. But I think I put them in position to deal with how we get their child better at dealing with aversive learning. How do we get them to tolerate something, whether it be disgusting or some other aversive emotion, that they have to get to the other side, they have to create new learning for. And I say gonadal hormones are important. And one of the metaphors that I'll use is that I'll ask them to think of at age 10, what did they think of kissing? And they'll say, it was gross, yuck, normal response to it, right? And then I'll say, and what was different at age 16? Fantastic, wonderful, the best idea I ever heard of. There's something about gonadal hormones, and particularly that developmental window, that's really important for reducing disgust. There are probably a host of molecular and circuitry-related things that happen to support that change that have implications beyond just learning how to kiss someone and like it, but also have associations for how to face fears or deal with threat in a whole host of ways. One of the things that we've begun to learn more and more about is how essential endocannabinoids, or your body's natural marijuana, which is a lipid signal, are essential for reducing or updating these sort of negative aversive associations, which we can argue disgust is a fundamental component of. And there are things like polyunsaturated fatty acid, or PUFAs, that contribute to this. It's all too complicated to explain to a family. Usually what they come out saying is like, should we be giving marijuana to our child? The answer to that is no. But I think that there's hope, I think, for us learning how to get better at this process of new learning. Oxytocin is another one of these. There's clearly, it plays some role. It's been sort of experimentally shown to reduce disgust and also for improving social emotional functioning. It may be an essential piece to that very equation. Again, when we cut off the HPG axis and we reduce oxytocin in the brain, we may be limiting our ability to reverse those negative associations. And one of the reasons why we don't see big changes immediately upon weight restoration is that it takes time for these systems to be contributing to that social emotional development in a healthy way, and why it may take a year or so post weight restoration for us to really see changes. Okay, so moving from that, we talk about this idea of treatments for pathological anxiety, and we know that most of us know that exposure therapy is probably the most robust talked about treatment. We know that it's basically breaks down to repeatedly presenting the threat without allowing some compensation. So classic EXRP. It facilitates a new safety learning to that threat, which allows you to consolidate this new memory that this thing that was once scary is no longer scary. However, if the thing that you're afraid of is an interoceptive signal, exposure is much more difficult. It's not necessarily the cue, like the food itself, that you need to be exposed to, but instead the actual fear is a response to the feeling, the internal one. And there are other forms of exposure therapy that target that maybe more specifically. And we talk about interoceptive or kind of a mindfulness-based exposure. There are also cognitive interventions to modify attentional biases, for example, in worry exposure that have been shown to be effective. So if we think broadly about, if we understand the sort of anxiety model within anorexia nervosa as a treatment target, we would be thinking about all three of these as potential avenues depending on what was being presented. So how do we treat disgust aversion? So this would be the new one. And one of those particularly would be, or I guess the two primary interventions when we think about disgust are counter conditioning and stimulus reevaluation. And they sound very similar, but they're actually different. Counter conditioning is really just branding. It's pairing two things together that may have no logical connection to each other. So I always give the example, it's sort of like, babies and some scary image. You put the two together, they don't have any connection to each other, but you can transfer the positive valence of that smiling baby to that negative image just by pairing them repeatedly together. Stimulus reevaluation is a cognitive tool that has you take the negative image and assign a positive value to it by thinking about it in a different way. And an example of that might be if you're changing a newborn's dirty diaper, you can think about it, the negative concept of it smells bad and it's gross, or you can think about I'm saving or helping my child avoid the distress of a dirty diaper. And so that kind of reevaluation, stimulus reevaluation, both of those have been shown to be effective at dealing with disgust-based learning or trying to reduce the disgust response. Interoceptive exposure really combines those two approaches with this eliciting of somatic experiences associated with eating, and that we can use both of those strategies in this context. So the summary of clinical implications, we talk about disgust conditioning as being extremely difficult to extinguish. We talk about that with families, about how overcoming that disgust is very difficult. Often we will actually even have them conceptualize and participate in the family meal by eating something that they find very aversive. And so we've had families bring in foods that they hate, that they can't stand, to demonstrate to the identified patient that they can use the same skills to tolerate eating that. Interoceptive exposure, which is traditionally thought of for panic disorder, now being applied readily to IBS, can be adapted for anorexia nervosa, and we can use some of these same strategies informed by neuroscience to make those changes. And we talk about it largely for integrating it into what we called FBT exposure, where we train parents how to be really good exposure therapists and to help identify those emotional states and design exposures for their children based on those learning principles. That basically runs me out of time. So I would like to use the last couple minutes to see if there are any questions related to anyone. These are kind of our summary of our main talking points throughout today, actually. And so hopefully there are a host of questions that we can try to answer all in 5 minutes.
Thank you, Tom, for that fantastic and informative presentation. I don't see any questions yet on the side, so I'm just going to throw it out there. Does anyone have any questions? If you do, please type them in the chat box on the bottom right-hand corner. We'll give it about 30 seconds or so, and then I'll turn it back to Tom.
Looks like maybe I've answered all the questions. I guess one of the things I'd just say is thank everyone for attending and listening. You can feel free to reach out to me if you have any other questions along the way. I'm happy to answer them. And